All right, good afternoon, everybody. My name is Garrett Schmidt. I am the managing editor for ACO Exhibit Hall, and I'd like to welcome you all to today's webinar by BetterNight called How Managing Sleep Medicine Has Saved One ACO Millions. And I'm really excited about hearing from our speakers today. A few items of note before we get started, some housekeeping stuff. All attendees have joined today in listen-only mode, so you don't need to worry about muting your microphone. That's been done for you. And also the webinar is being recorded. So this will give you the opportunity to rewatch the session and or share it with colleagues, and we hope that you do. Afterwards, I will send each of you a link to the recording via email, and you can also download the slides there and visit the BetterNight booth and whatnot. Finally, during the webinar, we definitely want to hear from you, so we'd love to hear your questions, and you'll be able to submit questions at any time during the presentation, so you don't need to wait to the Q&A session at the end, but you can do that through your attendee control panel. And for those questions that we are not able to get to today, that we will make sure to follow up with you via email afterwards and make sure we answer those questions. So without further ado, let's get started. Our presenters today is Dr. Lynn Milgram, who's CMO of Sharp Medical Center, and Dr. Dominique Munafo, CMO of BetterNight. So Dr. Munafo is going to kick us off. So welcome, Doctor.
Thanks very much, Garrett. It's really a pleasure to speak with you all today. Talk about a couple of things that are very near and dear to my heart, sleep medicine and the ability to save some money. So my background is in pulmonary critical care and sleep medicine. I've spent the last 25 years or so working to try and improve access to cost-effective sleep medicine care. But before we get into that too much, I just want to talk to, for those of you who are experiencing maybe some heavy eyelids or maybe a little head bop, particularly those on the West Coast where it's 1 o'clock. I just wanted to show you a little bit about the physiology of sleep. So you can see here on the top, your sleep load from 7 a.m. inexorably increases throughout the day. On the bottom is your alerting force. And so by 10 a.m. in the morning, you're maximally alert. But about now, your alerting forces have dipped. This curve here is the integration of those two forces. And you're in this little shoulder over here. And that's why after lunch, we all have that little sinking spell. So if you on the West Coast, if those of you on the West Coast nod off a little bit, I'll be understanding and I won't take it personally. But for those of you on the East Coast, you should be here in your second wind and hopefully you'll stay alert. If you don't, then it's probably my fault. Well, the CDC has made it clear that we're dealing with a public health epidemic of sleep deprivation, insufficient sleep. A lot of that is self-imposed. A lot of us go to bed at midnight or wake up at 6 in the morning. And if you do that, you just don't have the opportunity to get the 7 to 9 hours of sleep that the American Sleep Foundation recommends. But for tens of millions of Americans that suffer from underdiagnosed sleep conditions like obstructive sleep apnea and insomnia, it can dramatically worsen this public health epidemic. So you can see on this slide, estimates are that as many as 18% of the US population is affected by obstructive apnea. Annual costs are very high in terms of medical costs as well as lost productivity. In addition, about 20% of the population suffers from chronic insomnia. If you add on top of that those that have transient insomnia, that number can almost double. And again, the cost in terms of healthcare costs as well as lost productivity can really be quite staggering. Now, if you look on the far right, in those patients that have obstructive apnea, there's a very high prevalence of a number of other conditions. So it's estimated that 46 to 53% of apneic patients are experiencing hypertension. Over 3/4 have obesity and overweight. A wide range between 5 and 63% are experiencing symptoms of depression, and about 1/4 of apneic patients have coronary artery disease. Similarly, if you look at In other populations, such as drug-resistant hypertension, about 83% of those individuals experience obstructive apnea. About 71% of type 2 diabetics have apnea. Over 3/4 of heart failure patients experience apnea. 44 to 72% of those that have had a stroke are found to have apnea, and about half of patients with atrial fibrillation have evidence of obstructive sleep apnea. Now, there have been a lot of studies done across many different cohorts that show the risks of untreated obstructive apnea, all the way from ranging from increased risk of dying from heart disease, risk of stroke, more likely to develop hypertension or suffer from a non-fatal cardiovascular event, increased likelihood of developing complex arrhythmias, recurrent AFib, and again, the risk of heart failure. So it's clear that untreated obstructive sleep apnea really has a detrimental impact on our health. When you look at that picture in economic terms, again, the data are clear. Higher direct medical costs during the 10 years prior to a diagnosis. And if you look at the study on the left, the Butterfield study, untreated OSA patients averaged 32% more hospital admissions than those that were treated. And on the right-hand side, the McKinsey-Harvard study showed that prior to diagnosis, OSA patients were utilizing medical resources far more than the control group. These highly prevalent conditions, and in case of obstructive apnea, severely underdiagnosed, again, can lead to very high costs. So if you look at the top study and the bottom study, anywhere from $1,950 as much as $5,200 per year for those with untreated obstructive apnea. And in the middle, they found that inpatient costs were actually 82% higher in untreated patients as opposed to the treated patients. So what I've tried to do here is review a little bit of the science behind the need to treat obstructive sleep apnea. Here you see a very important study that you are all no doubt familiar with. This is data from the Emerson-Wickwire paper that was published earlier this year. This is the largest analysis to date, and it shows over 287,000 CMS patients. You can see there are over 10,000 beneficiaries that had obstructive apnea and over 276,000 patients that served as the control patients. And what Wickwire found was that untreated OSA patients demonstrated increased healthcare utilization and costs across all the points of service. So here you can see hospital visits, emergency room visits, outpatient visits, as well as prescription refills per month. In addition, Wickwire found that the untreated sleep apnea led to total mean costs that were much higher than those without sleep apnea. And this was particularly true in the 3 to 4 months prior to the diagnosis of obstructive sleep apnea. Now, the good news is that we can favorably impact these trends. And I know as ACOs, one of the things that you're very interested in is hospital readmission rates. So here you can see data from University of Pennsylvania, and the blue line across the top shows that there was no chance for hospital readmission. And those were the patients that were good users of CPAP. The orange and the black lines showed the partial users and the non-users. And you can see that over those 30 days after discharge, those individuals had a much higher chance of being readmitted to the hospital. Additional data shows that we can impact on diabetes. So CPAP has been shown to positively impact diabetes by reducing blood glucose levels, improving insulin sensitivity, improving glucose metabolism in general, and reducing hemoglobin A1C levels in diabetics. So if you look at all of this, it certainly is encouraging that we have the ability to impact these patients that have obstructive sleep apnea. Here again is more data that shows the impact on costs by placing individuals on therapy. This is data from the Union Pacific study, and you can see initially when therapy was initiated, the costs were a little bit higher for the apnea patients, but those lines rapidly crossed and then they diverged, so that after 3 years, there was a savings of over $2,400 for those individuals with obstructive apnea who were placed on therapy. Now, I know that this data is taken from a railroad, but if you keep in mind, obviously, this is a condition that's affecting 50 million Americans. So it's not just truckers or railroaders that are experiencing these issues and for whom medical costs are dramatically elevated. So if you look at this, you would say, okay, we're in good shape. All we need to do now really is get these individuals on appropriate therapy. But unfortunately, there's a catch. And that catch is that our sleep care management system all too often really is broken. It's siloed, it tends to be very costly, it's fragmented, and it's very time consuming. So if you look at the left side of this slide, you can see the primary care physician, the primary caregiver may be screening and then referring to a sleep specialist. After the sleep specialist, then a diagnostic study in a lab may be ordered. After that, another consult may be performed, and then after that consult, referred back to the lab for an in-lab titration, then another consultation, and then ultimately referral to a DME provider, and that DME provider, more often than not, doesn't specialize in sleep medicine. You can see all the red arrows down, pointing down, where people fall out of this pathway. The net result is the numbers along the bottom. So we still have the majority of people, over 80 to 85% of those with obstructive sleep apnea have remained undiagnosed. 50% of the ones that we do diagnose don't make it to therapy. And if we look at our adherence rates at 1 year, they're only about 33%. This whole process can take many months and at a cost of many thousands of dollars. So what I want to talk to you today about is that there is a better way to approach this sleep care management. And that better way is BetterNight. So what you can see now is a fully integrated and virtual care model that can also dramatically impact on the rate or the chance of infection transmission here and during our COVID epidemic. So if you look on the far left, again, we have an online sleep health assessment. That can lead to a sleep report and appropriate education. If necessary, a telehealth consult can then be ordered, and based on the results of that telehealth consult, a sleep test can be ordered. If that sleep test is positive, then therapy can be ordered, and then the patient moves toward the end of this protocol, which is CPAP therapy being initiated, the patient being put into a coaching program, and population health metrics being able to be measured. The net result of all of this is that we can dramatically improve the conversion from diagnosis to therapy. You can see here a 50% improvement in that. We have always had very high levels of patient satisfaction, and our adherence at 1 year is twice the national average at over 67%. All of this can be completed in a matter of a couple of weeks and at a fraction of the cost of the prior system. Again, this is end-to-end, it's integrated so that all of the information is rapidly available to all the caregivers along the pathway. And I think it's really important to note that the combination of 50% improvement in conversion and then being able to double the adherence at 1 year, that leads to 3 times the number of patients being effectively treated. And therefore, the money that's spent on diagnosis and therapy is not wasted because those individuals, there's so many more of them that are experiencing the positive benefits of therapy. Now, I want to give you a little bit more about what's behind the BetterNight platform. It's designed to be modular and adaptable. And the reason for that is because we know that there are many different practice patterns in the community. So we wanted to be able to be sure that we could accommodate those different models. So if you look at the left, you can see that we're able to perform the sleep health assessment from the very beginning and determine whether someone is at risk and whether or not they're having symptoms and how severe those symptoms and that risk is. That takes 5 or 6 minutes on a web-based assessment. If that's already been performed, then those individuals that have issues can be referred for an online consultation. And that's a physician-led and digitally based consultation. Now, if in your ACO, your providers have already performed that consultation and they simply want to refer to BetterNight for a diagnostic study, then that can be done as well. That's another entry point. And then we can send out a home sleep study directly to the patient's home. If the study has already been done and we have a diagnosis, then they can enter the system at therapy and be referred for CPAP. And you can see after the CPAP therapy setup, then we enter those patients into remote patient monitoring and population reporting. And I'll get into more detail a little bit about the population reporting and show you those reports a little bit later in the discussion. We also have a standalone module, a standalone app that provides cognitive behavioral therapy for those individuals that have insomnia. We know that insomnia obviously is a very significant problem, and we know that it's very difficult to deal with in a meaningful way in a very brief primary care visit. Oftentimes, primary care physicians feel that their only real option is to provide medications, sedative hypnotics, and that's obviously not the best way. So the Insomnia app provides cognitive behavioral therapy, which really is the treatment of choice for those that have insomnia. So what I'd like to do now is to switch gears a little bit, and I want to introduce Dr. Lynn Milgram, who is the Chief Medical Officer at Sharp Community Medical Group. And she's had over 22 years of experience with BetterNight and the systems that we have. And she can talk a little bit about how that's impacted her and her medical group. Lynn, I'll turn it over to you.
Thank you. Thank you so much, Dominic. So how exciting to be able to talk to you all today. Sorry, we're doing a virtual meeting, but that just seems to be the way it is today. Like Dr. Manafo said, I'm the Chief Medical Officer of Sharp Community Medical Group. I'm an internist by training. I am not a sleep specialist. I've been involved in an administrative role for many years now, over 20 years with Sharp Community, but I've also been involved with different health plans. I was with United, I was with Cigna, and I was with a hospital system. Sharp Community is pretty unique because we're part of an integrated delivery network. We have our own health plan. We're part of ACOs. And we've been doing volume to value for 30 years. So let me tell you my story and how we partnered with BetterNight. So this slide says we were a broken medical group as far as it relates to the diagnosis and treatment of obstructive apnea. I think that's generous. I would say we were dysfunctional, disorganized, inconsistent, wasteful, and I'll tell you why. When I came to our system, we were dealing with a national DME provider that supplied CPAP and supplies. It was kind of like going to Amazon.com and selecting a CPAP without any understanding of the patient's needs. There was no follow-up of our patients, no data, no outcomes. Poor compliance, again, is an understatement. I had no idea what they were doing with their CPAPs. All I knew was that they were ordering supplies. They could have been using them at garage sales. And ROI was unheard of. We had such expense because, as you'll see in the next few slides, we were using very expensive resources, both in the diagnostic, in the referrals, and certainly in the sleep studies. We only did those expensive inpatient monitoring sleep studies. And you know, as an internist, my PCPs were so confused and so disadvantaged. They really did not know what to do with these patients. Long before Dr. Manafo will show you some of the sophistication BetterNight has now, we came up with an easy way for our doctors to screen these patients. Thank you. So here's the story. My organization, I partnered with BetterNight. Why did I do that? Because I knew that they knew sleep. I needed a provider. I needed a partner that knew sleep. And yes, they're a sleep-only DME provider, but there's so much more than that. And that's what we developed together. They are our care management partner. They were able to follow these patients. And I'm not even talking start to finish. I'm talking across the continuum of care. When Dr. Manafo showed you all those silos, we no longer have silos. We were able to demonstrate compliance and excellent compliance with CPAP. As far as an ROI, I was able to budget what I needed for these patients. I knew exactly what my spend was going to be. And like Dr. Manafo showed you, and I know you all know this, all those offsets in costs, those ED visits, those hospitalizations for the secondary illnesses, those went down, and we could demonstrate that. We definitely curtailed the use of those limited and expensive inpatient studies, which are not necessary. And again, so importantly, my PCPs were integrated into this space. And when you're dealing with an ACO, a system from volume to value, you want your PCPs to know what to do. And here's some of our results. So we have 4 bar graphs, before BetterNight, after BetterNight, starting on the left-hand side. You can see that before BetterNight, they could have a consult with an ENT, a consult with a pulmonologist, a consult with I don't even know who, but we had so many consults. Afterwards, that went down, dramatically went down. The diagnostic studies, as I told you, if they did 1 sleep study, 2 and 3 were better. They did split night. They did CPAP titration. They did studies they didn't need to do. Again, it went from over 2 studies, almost 3 studies, to 1 study. All of those expensive inpatient studies that we did 90% and only 10% of those home studies, it changed completely. We went down to 10% or less of those expensive studies. I don't even do those studies anymore. They're all done with BetterNight home sleep studies. I think we have another slide demonstrating some more studies. Before BetterNight, we were lucky if we had conversion to 50% to therapy in the beginning, but that didn't last. After BetterNight, we had 75% conversion, and at 12 months, we could show a 3 times increase in the number of adherent patients at 1 year. And before, I think that's my last slide, Dominic, before I turn it back to you, what I want to say is, my system was probably like a lot of your systems today, or maybe you are doing something like this, but we were not. We were definitely disorganized and dysfunctional and inconsistent. And today, this is an area that honestly, I don't think about. We have a partner. I know our costs. I know our patients are going to be well taken care of. I know at any given time what our patients are doing. And not to be too cliche, but it's a disease state that I never lose sleep over anymore. So that's all I have to say. I am going to turn it back to Dominic to show you his platform that we use.
Thanks very much, Lynn. I really appreciate you taking the time to talk with us. What I'd like to do now is talk a little bit about how we accomplish that and what's behind all of this. So we have a proprietary software package that we call Clarity. And what it does is it provides unprecedented ability to look at outcomes, produce outcomes with excellent accountability and visibility. The other thing that's really important is that it provides objective data with regard to how people are doing, not simply subjective data. We do exception-based coaching and management, and then we can provide ongoing therapy supplies when they're needed, not just on a schedule, but when they're really needed. The net result of all of this is that we can reach out to the right person at the right time with the right intervention. So Clarity has a number of inputs, and you can see on the left here, we take inputs from the EMR. We have patient notes. We have sales orders with regard to supplies. We know their CPAP usage in detail, and we know their sleep study and their severity. All of these inputs and more go into the Clarity engine. And the output from Clarity, which is updated on a daily basis with tens of thousands of patients, allows a BetterNight sleep specialist to find those individuals in the crowd that need that intervention and can then target those people and be very efficient and effective. Now, I talked a little bit about population management, and I just want to give you a little bit more details around that. So here you can see some of the reports that we can produce. On the left-hand side, that pie chart shows diagnostic status for 685 individuals. And what's really important about these pie charts is not so much the slices of the pie, what they're labeled, but the fact that we have all the slices of the pie. We know the denominator. We know where everybody is. We can track them and make sure that every person is accounted for in their journey through their sleep management. So you can see here on the left, there were 541 completed HSTs. That 541 then moves over to the right side, and this pie chart gives you an idea of which were positive, which were negative, which ones were positive from an outside source as opposed to positive from BetterNight, and those that were negative. So again, we have total accountability and visibility into how your patients are doing. Now, if we move into the therapy side, we have the same ability to produce these detailed reports. So now these are folks that were referred for PAP therapy. And you can see we know where they are in the process, whether they're just going through the intake process, whether the therapy hasn't been prescribed, whether they refused it, whether it's all in process, or whether they may only be getting supplies, or for some reason, if they're not responding to us, we know that as well. And then on the right-hand side, again, our ability to track them, we use modems to help track that data. So you can see we have internal modems and external modems, and we know how each of these folks are doing every day. We update the system, and then that data gets collated. So here is an example of the reports that we can produce. So on the top left, this breaks down the apnea severities for the population, mild, moderate, and severe. On the right-hand side, you can see we have active modems here. This tells us the average nights that it was used. Also, the average hours that were used. You can see here at 4.94, which is excellent usage. And then the treatment AHI. So you want this number to be under 5. So we know that it's 2.61 events per hour. And then ultimately, what's really important is that we have compliance. Again, industry-leading compliance. These are levels that are very hard to generate and are probably twice what the national average is at 77%. And then on the bottom, the aggregated patient satisfaction numbers have always been really quite high. So I think, again, when we talk about accountability and visibility, when I talk to Lynn at an operational meeting, I can tell Dr. Milgram exactly what her cohort of patients at Sharp Community Medical Group, what they're doing, how effectively they're being treated, the number of hours that they're wearing the device, and she can feel confident that her population is actually getting a benefit from the services that they've provided. Now, to give you a little more perspective in terms of scope, keep in mind, we've been doing this now for over 25 years, and we have a staff that have trained at some of the most prestigious institutions in the United States. We are licensed nationwide. We're treating over 30,000 individuals every year, and we've always had very high levels of patient satisfaction. Our long-term adherence is, again, about twice what the national average is. And on the bottom right, I really want to call attention to the fact that we publish our data. So you can feel comfortable that these data that are collated and reported are actually of a quality that can be published in peer-reviewed journals. So I think with that, I'm going to stop and open it up to some questions and any discussion that you might have about the things that we've talked about, and really want to thank you for your generous attention.
Great. Well, thank you both. That was a wonderful presentation. And we do have some questions that I wanted to get to. The first one being, and these are in no particular order, what do you do with the Medicare patients that have an HST? Medicare regulations say the same provider cannot do a Medicare HST and then provide the PAP. Do you refer out that patient to another DME provider?
Thank you, Garrett. We have been able to achieve a structure so that we do have an entity that we can refer to that is separate from us, so that we can still take care of Medicare individuals.
Okay, great. And then the next question is, are you in all 50 states?
Yes, so we are nationwide. We're licensed in all 50 states. We can provide the telemedicine consultation as well as initiate CPAP therapy throughout the country.
Great. And then the final question for today is, what are the best methods that you would suggest to engage what seems to be disinterested PCPs?
Yes, well, you know, Lynn, perhaps you would like to talk to that?
Dominic. Well, I was going to take it from the point of view of an ACO, and I like to give data and show the spend. Then this is an area that I always see quite a bit of waste. So I find it to be an easy area to show how to decrease costs. So I approach it from an incentive point of view, but you know, Dominic, you may have a more clinical point of view.
Well, I think that typically one of the biggest issues has been that PCPs are often overwhelmed, and they are approached by so many people with so many asks to screen for this or screen for that, that it really becomes very difficult to take the time to do a detailed sleep health questionnaire, and then if it's positive, to be able to deal with those results effectively. I think the way we approach it is to say to a PCP, here is an opportunity to take your patient who you may have screened at risk and plug them into a system that can then take care of it from end to end and take the burden off of you and take the burden off of your staff. We know so many patients and so many physicians that the difficulty with following up. So the physician is overwhelmed by the data, by the software, trying to determine how their patients are actually doing. So we can take that burden off the PCP. So from my perspective, I think that the reticence of the PCPs is more because they haven't been given the resources that they need to be able to deal with the problem effectively. And what we say to them is that we feel your pain and we want to help you, whether it's to start with the screening itself, or if they've already screened, we can take those individuals at risk and move them through the system very efficiently and cost effectively.
Great. We actually did have a couple more questions come in, so we'll go to those. Next question is, how do you find interest/adoption by care organizations that are not necessarily ACOs, that don't have a value-based care arrangement? Are value-based care customers the best groups for you to partner with?
I would say from our perspective, there certainly are excellent partners, and our experience with Dr. Milgram at Sharp Community has certainly reinforced that. I think that all the folks that we've talked to, when they see what we can do in terms of improving outcomes, improving patient outcomes, reducing the burden of disease, they are swayed by that. I think, again, part of the problem has been that the system is so broken that all of the providers have seen tremendous cost, tremendous time that needs to be invested in order to get from screening all the way to effective therapy. So I think that we've seen interest across the board. ACOs, non-ACOs, all have something to gain by streamlining the care, reducing the time and the cost associated with getting their patients effectively treated.
Great. Next question is, did COVID-19 produce any findings with respect to sleep medicine?
Yes, that's a very interesting topic. And what we've seen is that COVID has accelerated what we think were already long-term trends in sleep medicine. So, for example, there has been a long-term trend over 2 decades now to move toward more home testing as opposed to in-lab testing. Clearly, with the advent of COVID, many sleep labs closed because the procedures for sterilizing the lab in between patients, the ability to keep the staff and the patients safe, the ability to make sure that the lab is still fully occupied, all of those things became quite challenging. So we know of a number of sleep labs that actually closed, and some of which may not open again. So that was one trend. The trend toward HST was another trend. And another trend that we saw was within home testing, the movement toward disposable recorders. So that is something that we also have the ability to do. So in this time of pandemic, we can use a disposable home testing device that doesn't get shipped back to us, and again, further diminish the risk to the patient as well as to the healthcare providers. And then I would say the other important trend that COVID has tended to accelerate is the ability to do a remote CPAP setup. So BetterNight has been doing remote CPAP setups for close to 10 years. And we've been working for many years now to perfect that ability to initiate CPAP therapy remotely without an in-person visit. So we have the educational materials and the protocols necessary to be able to send a device to an individual and then follow up with them and walk them through it and provide them with the appropriate instructions that they need to initiate therapy. We've done some research actually, and what we've found is that the time spent at setup may be less important than the actual follow-up time. And so our follow-up protocols allow us to do those remote setups and still achieve the same high levels of compliance. So our remote setups and our in-office setups have the same level of CPAP compliance, Medicare compliance. So I think COVID has accelerated all of those trends.
Great. Well, it's good that there's been some good come out of that. And then the last question we've got for today, and then we'll probably have to wrap up here, is how would you define the, quote, waste that ACOs could be seen in the data? Higher DME cost?
Yes, higher costs across the board. So it's very much higher diagnostic costs if you're relying on an in-lab study when an HST would be appropriate. And then that, the other cost are the consult costs. So as Dr. Milgram showed in her medical group, they were averaging over 3 consults per patient before you got somebody on therapy. So we can reduce that down to closer to 1 consult for a patient to get them on effective therapy. And then ultimately the CPAP itself, there are 2 areas in which we save money. One is just the cost of initiating the therapy is less. And then the other one is that there is an ROI, that there's a benefit because the individuals are actually using the therapy long term. So the ACO, the provider, the payer finally gets to experience the reward, the benefit, the ROI for having a patient who is effectively treated on CPAP therapy. So I think those are the main cost savings. Would you agree with that, Lynn?
Sorry, how to get unmuted. Yes, absolutely.
So I think there are savings, across the whole spectrum of that pathway.
Very good. Well, this has all been very exciting, and unfortunately, we are out of time and need to wrap up. But thank you both so much again. And for those questions, by the way, that we are not able to get in today, we will make sure to answer them via email. So keep submitting them if you would like before we wrap up here. And again, we will get back to you with those. As we conclude, I would like to encourage you all to visit the BetterNight exhibit booth at acoexhibithall.com. You can see that here on the screen. If you go to acoexhibithall.com and look in the exhibit hall, so you will find the BetterNight booth, and there you can interact with them and learn a little bit more about what they do. And also, this is where you will be able to find the copy or the link to the recording rather, and also to download the slides. That will be available in the reference library at acoexhibithall.com. Lastly, if you have any specific questions for Drs. Munafo or Milgram or the BetterNight team, their contact information is listed here on the slide. So feel free to make a note of that and to reach out to them directly if you would like, and they'll be happy to follow up with you for further discussion. So thank you again all for attending today. I hope you found the presentation informative and helpful, and hope you have a great rest of your day and stay safe. Thank you.